There you go.
Thank you. Hope everyone can hear me okay. If you can't, please let Sabine know through the chat function. It's a pleasure to be here. And yeah, just want to echo that it's been just a pleasure working with the team at Manchester these last few years. And I sort of say Manchester is my second home now, so I'm always looking for excuses to visit again. I'll do an introduction as part of my presentation in a second, but I'm just really interested today to talk to everyone about some of the work we've been doing bilaterally with India around inclusivity in healthcare AI. A little bit about me. So, I'm a digital health transformation research fellow at the University of Melbourne's Digital Health Validatron. So, the Validatron is a specialist digital health laboratory. I'll show you a photo in a second, but we have a simulation space and we help de risk digital health technologies because, as many of you on the call appreciate, there is a big implementation gap from evidence into practice where a large percentage of digital health innovations fail when they get into the real world. So that's sort of the role that our lab fills it by working with partners to de-risk innovations. For me personally, I've been helping build a program of work on digital health equity and co-design, and I also helped start up a digital health equity hub between the three universities, which is part of our trilateral partnership, the MMT partnership that many of you may be aware of. So I'm from an interdisciplinary background. I worked in industry for about 10 years before becoming an academic. And in academia, I am focused on translating patients, carers, and professionals' lived experience and tacit knowledge into the way we conduct digital health innovation. From a research methods perspective, I'm purely a qualitative researcher. I really enjoy working with the raft of both traditional and non-traditional methods, and I also bring in creative approaches in my work, things like photo elicitation, poetic representation, and simulation approaches as well. So this is a photo of our lab. So this is basically a suite of physical themed rooms. So you can see on the right, there's a GP consultation room. On the left, we have a patient home space, and in between here is the control room. We also have a hospital space as well, which is not shown in this photo, but the idea is to provide a full immersive experience to digital health innovators to come in and play act the scenarios of what it might look like if a new technology was slotted into the healthcare workflow, what might be some challenges, both from a usability perspective, but also things like workflow integration and so forth. We also have a digital health sandbox wherein we can put together the different components of a health services, IT infrastructure like electronic medical records, messaging systems, and so forth to really give that kind of immersive technological experience as well. Um, so moving on then to equity issues in digital health and AI solutions. Many of you may have seen this paper come out of the United States where it was found that millions of Black people had been affected by racial biases in healthcare algorithms. And this really brings home to me the concept of and the importance of capturing social determinants of health in the way AI algorithms are developed. So, for this particular study, for example, it was found that hospital hospital algorithms had actually discriminated against people of African origin because the algorithm was based on the expenditure that was being made in healthcare. And because African American people often have traditionally lower expenditure in healthcare, often because they have lower socioeconomic status or even just lower trust in the health system, their expenditure tends to be lower. So it had completely discounted that. And as a result of that, people had to be twice as sick as white people to get the same level of care. Um, Moving on then to this idea of kind of working bilaterally to promote inclusivity in healthcare AI. A little bit of background for those in the UK. So with India and Australia, it's sort of they hold annual bilateral leader meetings. They have a shared interest and ambition for a region that's peaceful, stable, prosperous, and they do that through a range of cultural, economic, and technology related ties as well. So over the last few years, they've invested just under $30 million to help advance sort of cyber and critical technologies. And that under this initiative, we were funded to advance inclusive AI governance in healthcare. So the project that we were involved in, or I was involved in, is called Project Build, which stands for Building Inclusivity by Design in AI ML powered health tech. So it's very much about embedding equity and inclusion principles upfront rather than as an afterthought. So the key partners on this program have been a law firm called Ikigai Law. They are a law and policy firm. NALSAR, which is one of India's premier law colleges, and CADE, which is the Center for Artificial Intelligence and Digital Ethics within our university. So this is one of our these are our colleagues in a different center. That's not the center where I work, but so yeah, we were funding to kind of undertake bilateral learning tours in India and vice versa to Australia and propose best practices for making AI and ML powered health tech more equitable. So essentially, if you just want to get a sense of the delegation from Australia to India, so I was part of that, but we had a real wealth of experience represented on the delegation. So we had people from industry like CEO of Health Engine, Dan Stinton. CSIRO is the country's premier scientific research organization. So we had Professor Dida from there, and we had other people from other universities, startups, and so forth as well. The Health Direct platform, actually, there is a similar platform in the UK as well. As I understand, there's a symptom checker that I think has been implemented in the UK as well. And so Health Direct, just for anyone's interest, they also have the country's largest video telehealth platform in Australia as well. So we had their chief medical officer come along. So through that project, we helped co-design an inclusive AI in healthcare toolkit. I would be very happy to share a copy of this along with my slides afterwards. But just to give you a little bit of idea of what this looks like, so we were thinking about, well, how do we even define inclusion in AI in healthcare? And we've landed on this idea that diversity and inclusion in AI in healthcare is about the inclusion of humans with diverse attributes and perspectives across the data processes, systems, and governance mechanisms within the AI ecosystem. And that, as a result, then helps with ensuring health equity. Now, with the co-design toolkit, we kind of came up with 4 buckets of considerations that should influence inclusivity within AI in healthcare. So number 1 is your consumers consideration. So consumers in Australia basically refers to the patients in public because they are consumers of healthcare. Certainly not everyone likes that term, but that's sort of the term that we use here. So that includes things like lived experiences, digital health equity, what are their barriers to accessing healthcare, how the technology might impact them. From a clinical consideration perspective, it's around the realities of providing healthcare to people, known challenges of using AI in healthcare, and any inbuilt bias-related concerns. There's also other issues around like disease-related information, prevalence, variances within diseases. So one example of that would be that, for example, cardiac failure symptoms appear differently in women compared to men. So how do these variances and so forth get addressed within AI algorithms? And then the last piece is around technology, which is around the different layers of technology required to provide AI customization to specific contexts, security, privacy, and so forth. So as I said, this is just me touching on briefly. This was a large program of work that was done over 2 years. Very happy to share a copy, but I kind of then want to move along to some of the work I've then helped expand this further. So just for anyone's interest, so the University of Melbourne has invested in a global center in Delhi where they invite the global academic community to come and visit and hold events and conduct outreach both for students as well as government, industry, and other academics. So these were my partners in crime, myself, our clinical simulation expert, Teresa, our acting director at the time, now our research director, Dr. Kid Huckvale, and Ikigai Law team as well from India. We were also lucky to have industry partners. So we thought it was really helpful to have industry representation. So we were able to invite 2 colleagues from Melbourne who have created this algorithm to help make chemotherapy dosing more person-centered and precise, and as a result, help reduce toxicities because of chemotherapy. So we were able to bring them along as well to offer the industry perspective. And so we conducted this day-long policy recommendation workshop. And I'll talk a little bit about how we addressed equity and inclusion for that piece of work. And I think it's really good to maybe start about the conceptual framing of it all. I'll also keep an eye on any questions. Happy to take questions at the end, but equally, yeah, feel free to jump in as well if needed at any time. So just to then get on with the framing of equity and inclusion, we thought about it from two aspects. So one is your equity and inclusion in outcomes and equity and inclusion in the process. If you've ever heard me talk, which is possible because I visit Manchester from time to time and I've given this talk before, this is the framing that we use within our trilateral partnership as well. So my apologies if this is repeat information for you. It's just two slides, so if you bear with me. So the first piece is around equity and inclusion and outcomes. So this is all about mitigating unintended consequences from our project. So if you cast your memory back to the initial example I gave around the hospital algorithms, those biases and things like that, those are unintended consequences. And legitimately, some may say that it's unintended, but it's not necessarily something that cannot be anticipated with a little bit more thinking upfront. So that's the first piece, to actually reduce unintended consequences, but also things like potential exacerbation of barriers to access as well. Aspirationally, however, we want to be a facilitator for narrowing the digital health divide across the population and reaching groups who may otherwise face barriers to access of care, whether it's geographical, stigma related, and so forth, and certainly improving quality of care for underserved communities. From a process standpoint, we really believe that by embedding equity and inclusion and diversity upfront in the way we do digital health innovation, that kind of gives us a little bit more insurance for making sure that actually the outcomes we have or the technologies we develop will end up being more equitable as a result of us having embedded those perspectives upfront. Problem with that is you can do co-design and co-creation in a way that's very tokenistic, or you can do it in a really meaningful manner as well. So really thinking about our methodologies for how we engage consumers. There is a concept called hermeneutic justice, which is all about interpretive justice. And that's very much about making sure that the tools we offer to our healthcare consumers to participate actually is something that's viable for them. So one example is, let's say someone's got a motor neuron condition and we use surveys where they have to type slabs of text and it's not going to be possible for them to participate. Or we may be working with older adults who don't have internet access and we are doing co-design through Zoom calls. So it's a very simple reductive example, but you get the idea that it's really important to use tools and approaches that actually help sort of do co-design properly. And we've actually just hot off the press, we've got one paper that's just come out, and happy to share a link of that as well with the slides, which is about methods adaptations for co-design. And then the next thing is also thinking about, well, what is it that we measure? What does success look like for this AI algorithm? And this whole idea that what gets measured gets managed. So it's really thinking laterally about what is it that we should be measuring? Are there certain equity related outcomes that are important for business as usual evaluations and so forth? And as I said, just thinking about our evaluation methods as well. So with that framing, moving on then how we conducted the workshop. So this workshop was attended by a wide range of stakeholders, from clinicians, patient advocates, academics, industry professionals, lawyers, ethicists, and we also had representation from the World Health Organization. So we had three types of use cases that we had given to all the groups, and so there was a bit of repeat. So we had printed vignettes on each table. We had one option, which was an AI scribe. The other one was a clinical decision support tool underpinned by AI algorithms. And the third one was a patient-facing chatbot for mental health. So we gave a use case to each group just to help them step through their thinking. And so the idea was for them to work in groups to generate recommendations and considerations for responsible innovation for each use case. And that was then split across a very high level kind of life cycle of a digital health innovation that may be powered by AI. So starting with problem exploration, design and development, evaluation, and implementation and monitoring. So the overall focus was to then develop policy adjacent instruments. So we weren't looking to expand software as medical device regulations right this minute. It was very much about developing policy adjacent, regulatory adjacent policy recommendations. So this is the fun part. This is sort of our emerging themes, very open to feedback as well and comments from the audience afterwards. But maybe I'll talk you through it, and then it'll pretty much be towards the end of my presentation, and then we can have a discussion as well. So the first piece that came up was around data solidarity. So if you work with communities, particularly marginalized communities, you may have heard about the term data sovereignty, which is about making sure that people have control over how their data is being managed and so forth, and who is accessing it for how long, for what purpose, and so forth. Data solidarity, on the other hand, is about data commons and data access, so that the idea that data can actually serve as a real useful tool if utilized correctly for communal benefit. So we looked at recommendations around data solidarity. The second piece was around life cycle oversight, and this is about oversight and ethics review boards post deployment. So not just during co-design, because I feel like a lot of us are pretty good at having consumer representation while we are designing something, but really it's the implementation and post implementation piece that's often missing. And this actually also relates to your backend infrastructure like data centers and so forth. And how can we actually include consumer representation for oversight? And this is particularly important for the Australian context, where there's a huge history of discrimination and colonization of our Indigenous people. So it's really important to think about life cycle oversight. And a lot of data centers often sit on country which was never ceded and so forth. So that's really important to think about as well. The next piece is around stage gating of evidence. So anyone who works in digital health probably appreciates by now that often randomized controlled trials, which may be considered the gold standard in a pharmaceutical trial, doesn't necessarily apply to a digital health intervention for a raft of reasons, whether all the way from, well, it's personalized to the patient, so there isn't a specific dosage you can provide for a digital health innovation. So it's really helpful to think about how do we actually stage gate evidence generation of AI algorithms. And some examples of that could be things like doing silent trials or clinical simulations and so forth. And really sort of helping generate evidence as a bit of are we ready to go to the next stage? Are we then ready to kind of take it into the real world? And this is also particularly important because I've heard horror stories of innovators and startup companies that have gone to clinical trial too soon. And just because of certain things hadn't been ironed out before, there is a lot of attrition of participants. Clinicians don't want to use it, and millions are lost, and shops get shut down. So it's really important to think about that as well. The next piece is around explainability. And one of our experts actually came up with this idea of similar to food labels, where we often have food labels in the supermarket. It makes it really easy for us to understand. And so having some explainability around algorithmic input disclosures and standards for labeling also emerged as an important piece. The next one is around lived experience, which sort of talks a little bit to life cycle oversight, but very much about embedding lived experience expertise throughout the life cycle of the AI innovation, beginning at the very start at problem identification stage. And this is once again really important when we think about marginalized communities or communities from culturally diverse backgrounds. Because if you think about it, a lot of communities have different notions and meanings of what does health and well-being even mean for them. So an Indigenous community may see health as a very communal, multi-dimensional sort of concept, where even things like environmental health, quality of their relationships, kinship, and so forth are really highly valued. And so really thinking about it from the very start, what is health and well-being is really critical. And again, all the way to your sort of post-market surveillance, not just for the algorithm itself, but for backend infrastructure as well. And then the last piece is around bias safeguards, because, so for example, we had a disability advocate and a person with a disability also attend, and they raised this idea that often models can be actively used for exclusion. And so having guardrails to prevent underserved communities or marginalized communities being excluded from these algorithms is also really important. I've got a QR code. We also then had a little bit of success at the AI Impact Summit in India early this year. We had a panel discussion and published a little compendium on how we can de-risk the algorithms for implementation in the real world. And I talk a little bit about the Validatron lab as well. If anyone's interested, do feel free to scan the QR code. I'll leave that in for a second. And you'll have access to the slides afterwards at any rate. So in terms of next steps, we want to expand the work to incorporate environmental sustainability. And the reason that's really important is, number one, if you tune into the news of late, there is a lot of pushback on data centers around the world. There's a lot of community resistance. A lot of countries are asking for moratoriums on more data centers and so forth. So I just think health equity cannot be treated in isolation with environmental sustainability. And often the reason for that is the places where these infrastructures exist and the communities which are most impacted by the environmental impacts of this infrastructure are often the ones that benefit the least from it. So to give you the context for Melbourne, often these kind of infrastructure would be in the western suburbs. They have often lower socioeconomic groups, often people from culturally and linguistically diverse communities who are already underserviced by the health system. And so just to really think about that, like it's a double whammy for some communities where they don't even benefit from these innovations. So really thinking about it holistically. And then the next piece is around facilitating broader international collaboration beyond the two countries, working towards globally harmonized policies for inclusive AI in healthcare. And so our partners in WHO have expressed interest in this idea of harmonization. So it's really helpful to think about how that can kind of become a point of global consensus as well. Thank you. Please do reach out. I'm on LinkedIn and my email address is on the screen. Please do reach out anytime. I'm very interested in just even having a social call, learning more about what folks in Manchester are up to. And yeah, please do reach out if this is a topic that's of interest to you. Thank you.